So I'm going to ask you to describe in words what you see on a screen, which I'm sure is going to translate beautifully for our audience. But when you're looking at something, what gives you a hint that this is an early recurrence versus this is more likely inflammatory? Is it a specific look? Is it a textural? Is it a color? Is it when it's over a prior scar? Are there any visual cues that through your years of experience you've kind of garnered where you're saying, I think this one might not be a recurrence. I think this is inflammation. We're still going to do all these other things to check, but in your mind, what do you look for your own personal sense of reassurance? What do you teach your fellows?
Yeah, I think that's tricky because I do think it's such a sense of things. But again, for CIS, I think that particularly with blue light in the clinic, really looking for sharp edges of demarcation is really helpful because you can have all kinds of perceived false spots. When you look in with a flex blue light or even not, everything kind of looks pink, but if you move your scope and you continue to see those well-defined edges, I also really look for sort of a well-defined edge where, to me, it looks like all the vessels are blurred out. I don't know how to say it in any better way than that, where, I'm not really seeing, in CIS, I'm not necessarily seeing hypervascularity in that lesion, but more of a sort of a hazy appearance that is well-defined and that maybe weeps as the bladder is filled, a little bit of early bleeding. I mean, that's all really subjective, but...
No, but that's exactly, I agree, because those are all the things you're kind of thinking. That's why I asked you to put them into words, because it is a vibe that you have from it.
Yeah, I mean, I think the thing I have the hardest time assessing is patients who've had a fairly extensive TUR and really assessing the base of the old TUR site. So there, I think all bets are off. I mean, often it's calcified or fluffy, and I'm really just looking for papillary disease in those situations.
Yeah, I would say I agree with all of that. I think sometimes, people use the term furry or velvety.
Velvety, right.
I think those are applicable in some situations. If you are using blue light and you touch the area that's lighting up and you see particles floating around.
Scratch test.
Yeah,
yes.
That was scratch test. I think Sia kind of described that in a paper. That I think is maybe more suggestive of CIS. And I think, definitely bleeding. But I'll often use blue light in post-trimodal patients to look for non-muscle invasive disease. And that's where I think it's even trickier. So, let alone people who've been treated previously with intravesical therapy, I think even that space, it's even harder to get good diagnostics.
I think part of that, and I know everyone has their own algorithm, but because of that difficulty, when patients have had induction BCG, unless they absolutely refuse, I take them back to the operating room for that first biopsy for my first cysto, particularly, really high-risk patients, because I don't still trust my visual interpretation enough, and I don't trust cytology enough. And so I'll go back in patients who have had extensive CIS particularly and rebiopsy them, no matter what, after induction BCG.
Do you find that patients, I'm sure both of you have experience with gemdosi as well, do you find that the visualization is a little bit easier with that as opposed to BCG, the inflammatory reaction, or about the same?
Maybe a little better.
Yeah, hard to say. I mean, they some of these patients, the bladder just responds really, really aggressively to any sort of installation. So it's hard to say. But yeah, maybe the bladder looks less inflamed in gemdosi, but that's very subjective.
Yeah.
And everyone's different. I mean, everyone is so different.
I agree. I think that that's kind of part of the art of it in some ways, and that's why we need more objective data. That's why we're talking about biomarkers. That's why we're talking about repeat trips, adjudication, all of this stuff, because it is so subjective, and our patients want a little bit more clarity in this space. So when you are talking to the patient about it, their new diagnosis, their recurrence, their journey through this space, do you use any risk calculators in these conversations? I find that with bladder, I don't rely on a risk calculator the same way that I do for prostate consistently. And when I've tried to use the EORTC calculators, I find myself trying to explain what's not in the calculator and what it doesn't factor in more than I'm explaining why I'm using it. And so I've backed away from doing it consistently. Do you incorporate that in your counseling?
I do in some patients who sort of want a number. Some patients are just, your typical engineer, who is driven by numbers will say, hey, like, what is the percentage? And for those patients, I will. But I will set this up by saying this is a lifelong disease, unfortunately. And, we'll probably grow old together, and we're going to be looking at your bladder very carefully, and you're going to have a high risk of recurrence. That risk is going to be highest in the first 2 years. The longer you go without a recurrence, the better off you're going to do. But we don't really know when to stop surveillance entirely. I once saw a patient who had a recurrent tumor, 13 years after going with no tumor. So I think if you set them up for that, most patients say, okay, fine. And I tell them we will decrease the frequency of surveillance, and eventually this will be like, going to the dentist. Like, nobody enjoys it, but you get it over with and then you're good for a while. And so I think that's kind of the framework. But I do like the EORTC calculator. I think it has some merit. There's also a paper published in European Urology, Schuckman et al., which gave a recurrence table based on what the initial index tumor was, and then what the risk of recurrence is at each month, like each 3-month interval after. And you can see a nice progression downward. So if patients are really interested, I'll give them a copy of that article and say, look at this article. But most patients, they don't want a number. They just want to know what is the long-term game plan.
And do you use anything else, or you kind of just talk about?
Yeah, I agree. I mean, I think we use risk stratification. I mean, I generally tend to use the AUA risk stratification and sort of talk about it just based on that. And I think like the EORTC calculator really incorporates all of those same factors just to put patients into risk groups. And so I do talk to them about what risk group they're in and what makes them be in that risk group. But beyond that, I don't tend to use a specific calculator.